Hello, and now we'll begin with CIN. So, cervix and its neoplasia, and its cancer slash neoplasia, whatever you want to call it, right? Neoplasia. Pardon the handwriting. I've never had a good handwriting, but but hopefully I've got a fair understanding of cervical cancer. All right. So first of all, what is important for us to understand in all of this is that the cervix has two parts. One is the ecto, and the endo. Right. Now, the thing about ectocervix is that it lies very close to the vagina, right? So, and we know that the vagina is usually, it's more, not usually, but definitely it's a squamous epithelium, stratified squamous epithelium. Now, because it's so close to the vagina, what happens is that the vagina actually the vaginal epithelium grows over the ectocervix, and the ectocervix also eventually has a squamous. The endocervix, on the other hand, lies inside, more proximally towards the uterus. So the endocervix usually has the columnar epithelium, right? It has the columnar epithelium. Now, there's a point that is between the ectocervix and the endocervix, which is called as the squamocolumnar zone, all right? And the importance is that the squamocolumnar junction lies at the external os itself, all right? Originally, so it lies as the ectocervix. All right, so now we are looking at here is the ecto, and that's why I've drawn it here. Now what happens is that as puberty occurs, the estrogen is released and acts on the columnar cells, and glycogen increases. All right. So what happens is that there is squamous metaplasia, and this kind of migrates inwards. All right. So the zone kind of changes and it goes upwards, inwards, right? Originally it was more external, and then it goes more up, right? It goes more up, it goes towards the endocervix. Does it go at the endocervix? No, not necessarily. That is something we'll have to find out, and that is something that we will actually look into. That why is the squamous epithelium at the endocervix, and that will kind of raise kind concern, right? It will raise certain concerns, and that's something that we'll actually look at. So there's two things, all right. This is your transforming zone. So your transforming zone is actually the difference between the original squamocolumnar junction and the new squamocolumnar junction, right? And because we are seeing this squamous metaplasia, the most common cancer of the cervix is also your squamous metaplasia. All right, there are two cancers of cervix: squamous metaplasia and your adenocarcinoma of the cervix. All right, now squamous metaplasia is much more common than the other one, and there's something that is an established fact. All right, so what is dysplasia? All right, let's address that. Once that is addressed, and the different types of squamous cell that you can actually see is addressed, we'll go for pap smear. All right, and once that is addressed, we'll go for the very important diagnostics of CIN. All right, now CIN, very important for us to understand, is that dysplasia is basically metaplasia that is occurring in your inorganized manner, all right, or in a disorganized manner. So disorganized cells. Now we've kind of divided into three parts. We've got CIN 1 to 3, right? We've got CIN 1 to 3 and CIS. The reason we spoke about dysplasia is because of this. CIN 1 is 1/3, less than 1/3, 1/3 to 2/3, greater than 2/3, and CIS is when it's carcinoma in situ. It's not invasive, it's in situ, but it's carcinoma. All right, so CIS, by 1/3 I mean, in all of these cases I definitely mean thickness, and that's something that I assume that any person who's watching this video knows. This video is specifically for people who have a basic idea. Unfortunately, it is made in such a way. All right, then once we've got that, a few cells that I want to speak about on PAP is ascus. Okay, first I always start with ascus, all right, because atypical squamous cells of unknown, but it's atypical, very important, unknown. Then we've got ASC, atypical squamous cells, which is basically ascus only, but ASC. Then we've got LSIL, low grade squamous intraepithelial lesion. Then HSIL, high grade squamous intraepithelial lesion. Then we've got carcinoma and C2, very important, right? So these are the squamous cell changes that you can see. Atypical squamous cell cancer of unknown significance, cells of unknown significance, atypical squamous cells, LSIL, HSIL, carcinoma, and C2. If there are glandular changes that you have to actually speak about, one is asgus, one is AGC, same as ASC but just glandular, and then we have the adenocarcinoma. Okay, asgus is same as ascus. All right, so that is again spoken about. Now, there is a classification that we've got. We've got this Bethesda classification according to Pap smear. We've got your biopsy, all right, or your histopath exam, and then we've got Bethesda. That Pap. Bethesda is your Pap. Now, if I'm saying if it's a 1/3, less than 1/3, or CIN1, that basically means it's an LSIL. Usually. If I'm saying it's a CIN2, or if it's a 1/3 to 2/3, all right, then most probably it's an HSIL. If I'm saying it's a CIN3, again it's an HSIL. So far it's understood. So far the basics is clear that what is PAP findings, what could be the PAP findings, what could be the histopath findings. I'm not going into the HPV. I hope everyone has it through microbiology itself. Okay, because there's no time to read the same thing again and again in medicine. Two important genes of HPV, E6 and E7. The way I remember is E7 goes and affects the retinoblastoma. E6 is the P53. Alright, closer to 5 is 6, so E6, P53. Vaccines, if it is important, we have a bivalent, a quadrivalent, and a nonavalent. Gardasil 9 is your best. We have types of 6, 11, 18. 6, 11, 16, 18, 30, 31, 33, almost 45, 50 to 58. It has genital warts and 6 cancers that happen. So Gardasil 9 is your best. You've got Gardasil also, and you've got Cervix. All right. Dose schedule, if anyone does ask. If it's more than 15 years old, you give 3 doses. 1 to 3, first and second month is the gap between first and second, and then from the second and third you have to give a 6 months gap, or a 3 months, around 4 to 6 months gap. If it's less than 15, then you have to give only 2 doses, first and second, with a gap of 6 to 12 months. But we don't really have to worry about all of this right now. We want to just get into the crux of it. So we've seen Pap smear, and we've seen what will be the changes if we do an HP histopatho. Correct. Now, a patient comes to us. We have the theory in place. What do you want to do? How do you want to screen? What are the things that should be considered, right? When should I screen? What should I do? Right? All of this. Very important. Right? Okay, so first of all, there are a few screening methods that are actually advised by WHO. All right. One is your triple screening method. All right, triple screening. Then you've got the low resource setting, high resource setting. Okay, so your WHO approach says something, and your ACOG says something else. Okay, first let me just explain, and then we probably will write, or we might not. Okay, ACOG recommends for screening in resource-rich countries. So the age to begin is around 21. Right, you begin at 21. Okay, you want to do your PAP, all right? You want to do your PAP, okay, as your screening, okay. Your PAP comes positive, your diagnostic, all right, and go for it. That's what your ECOG says. ECOG says, okay. What does the WHO say? WHO is a little different. WHO says, boss, you know what? There are two things that you can do. You could do either your C plus treat, or you could do C, do a triage basically three, and then you treat. All right. So if you want to if you want to see, right, if you want to see plus treat, you screen. Okay. If it's positive, just treat by LEP. Sometimes there is something as C triage treat. You do screen, then you do a second screen, or you could just proceed to your diagnostic, or you could proceed to your diagnostic. Better is to proceed to your diagnostic, because if your second screen is also positive, you'll eventually have to only go to your diagnostic, and then you have to treat. So this is what WHO says. Then what the WHO says in see and treat approach is that if you're just doing see and treat approach, right, if you're just screening, so what should be what should be your tests that you should be performing? It could be HPV DNA that you should be performing, because HPV DNA is a good test, all right, and you repeat every 5 to 10 years in your normal patients. But if it's an HIV patient, then you repeat every 5 year, and guidelines as such. All right, you if it's an FIV patient, you actually go from 3 to 5 years, depending on the HIV load and stuff like that. All right, or because we are saying that it's a resource limited area, you could also go for a visual inspection with acetic acid. Simple, yeah. And then you follow every year. But if you're a C triage and treat, then how do you want to go about? If that is the case, specifically C triage and treat, then you want to do 2 tests, right? 2 tests, and then you have to go for a diagnostic. So what 2 tests will you use? What 2 tests? You do your primary PAP. You do your DNA. Okay. So the idea about what WHO says is that you do your primary PAP and then you do your DNA. If primary PAP is negative, you don't need to bother. If primary PAP is positive, you need to bother. Okay, you need to bother. Or what you could do is that you could start with DNA and then go to PAP. Okay. And it's quite interchangeable, right? So if you're starting with primary as your PAP, if it's negative, you're fine. Just do your regular 3 year screening. If you're positive, hold on. Just hold your horses. You're negative in your primary DNA, just repeat it after 5 to 10 years. Repeat after 5 to 10 years. Repeat. And HIV has your different, as I've already stated here, 3 to 5 years. 3 to 5 HIV. If you're negative, okay? If you're positive, hold up. So clear up till here, alright? This is what the WHO says. Now, you've checked for your HPV DNA. It's positive. Go for a colposcopy. Most likely go for a colposcopy. Okay. Now your PAP is positive. What could be the findings on PAP? See, the thing I'm saying is HPV DNA is positive. You cannot have different findings on HPV DNA. That's why the best thing to do next is colposcopy. Obviously, if you want to do another test, you could go for a visual inspection acetic acid. You could go for a genotype. Usually you do a genotype, alright? You do a genotypic assay. HPV DNA is positive, go for a genotype. go for a colposcopy. You could also go for a VIA, but who goes for a VIA unless you're in a resource limited area? If you're in a resource limited area, why would you even go for a VIA when you have HPV DNA positive? Correct or not? This is just very simple, very logical thinking that you need to go about. Okay. So again, getting back to PAP, as I told you, hold your horses for positive. Now we'll speak about the positive PAP. All right. You could either have an ascus, right, or you could have something that is more than an ascus, as I told you. Now, as I already had said it before, right, in the start, and as I told you that ascus that is of unknown significance. So what do you need to do? You need to go for your triage test. And what is your triage test that you're going to actually pump you're going to do an HPV DNA. It's a positive, go for your, if it's a positive, go for your colposcopy. Straight, no questions asked. Negative, again, you do your rabbit, negative 3 early thingy. If it's more than an ascus, that means it's something like an ASC. If it's an LSIL, if it's an HSIL, LSIL is basically CIN1, HSIL could be CIN2, 3, CIS, but CIS would be different completely on the report. So what do you do in all of this? Do you go for a DNA? Do we? I'm saying no. Just go for colposcopy. I would ask a boss, you know what? All of this is a positive finding. Why do you not do anything? Why do we not go for it? Why do we not do a triage test? Actually, you could. You very well could. But do you need to? Why would you put an extra? Do you know there's something called as a quaternary prevention? Quaternary prevention is actually preventing doing more extra tests. If you're finding all of these clearly, you do not need to indulge in extra testings. Okay? A very important thing again I need to speak about is that let's say that you have an ASC, you have an ascus. Alright, you have an ascus. It's showing negative. There is a different idea where if you have an ascus or an LSIL, so, and if it's showing a negative, then you need to do an HPV DNA in 1 year, because there's a high chance, because it's associated with a certain amount of LSIL, there's a high chance that it could recur. So that is just a simple thought process that was actually told to me by someone that you need to do, and later on you need to probably get into that. But that is about it. I feel this is good enough. Ascus is important. A little bit about each test. HPV DNA testing is recommended in age 30 years. Can be done as 25. You could do it as a co-test, or you could do it as a simple screening test, reflex test, if it's done after an report of PAP. So you need to do it as a co-test or a reflex test. And that's something that we literally saw. This is your reflex test, and if we are doing it together, then it's a co-test. I mean, not even getting into it all, right? Positive, go for a colposcopy. Go for an ablation or LEP. Repeat after 5 to 10 years or 3 to 5 years in HIV. You could use it as a primary screening test now that we are speaking, as I had already said out here, as a primary screening test, HPV DNA. And yes, that is a very important thing that we actually got out of the way. Pap smear, 3 cells. You could have grading of PAPs also. Okay, Bethesda is different. PAP grading is different. All right. We've got reports of PAP that need. So if it's an ascus less than 25, all right, just repeat after your normal 1 year. Okay, if it's your look out here, ascus, you're doing an HPV DNA negative, just repeat after 3 years. You're not doing an HPV DNA, repeat after 1 year. Repeat back after 1 year. Okay. If it's positive and you're more than 25, you do your reflex test, which we've already spoken about. Correct. LSIL less than 25, just repeat after 1 year. More than 25, do a colposcopy. All right. HSIL and NASCH you cannot actually rule out. Colposcopy is actually visualizing. So because I already spoke about colposcopy is when you're actually visualizing, right? Again, it's a screening method, not a diagnostic method. Take a biopsy from the rough area, which is appearing white on acetic acid. All right. Um, the nuclear proteins coagulate. Uh, it has a green filter, so you could see your punctate mosaic reticular blood vessels. You cannot visualize the endocervix, which is why it's not diagnostic, right? Uh, so basically, it's used if you have an ASCUS, ASCUS, or and your ASCUS is positive on DNA. Um, if you have an ASCH greater than ASCUS, anything greater than ASCUS. Okay, so we check that. Um, once that is done, we need to speak a little bit about VIA. VIA is as simple as um, it's literally the same as colposcopy, right? And once all of this is done, you can go for something called as an endocervical curettage. Sometimes when the colposcopy is not seen. Now there are three types of transformations. All right, this is something which is kind of high yield, and I'm not going to write it down because I do not expect the listener of this video to be a retard. I'm not going to write it down. So the transforming zone has three. One is it's visible, straight up, ectocervix. Two is that it's not entirely visible, but it's at the endocervix. And three is when it's deep, it extends into the endocervical canal. Right? It's beyond. Right? So that's three. In all of these cases, you definitely need to go for a endocervical curettage. Endocurettage. Alright? If your transforming zone is of 2/3. I'm not gonna explain any of that. You just did. When do you not do it? You do not do it in a pregnant female for obvious reason. Endocervical curettage can be done as a conization procedure. Take a cone. How do you manage? Just a hysterectomy. Positive, go for a hysterectomy. Alright? So far, so good. If the childbearing is complete, if it's not, just make sure that you do your regular screening, you do your cryoablation if your criteria is fulfilled. You could go for an LEP, loop excision, and conization, obviously. Loop electroexcisional procedure or a large loop excision of the transformation zone. And these are the procedures that you actually do in CINs, right? Correct. So if you're doing an endocervical curettage, and there's no invasive carcinoma, you could go directly for a hysterectomy. Why? Because you do not want it to involve the deeper parts of this uterus as well. So it's better to get an hysterectomy done. And I think so far there's nothing more clearer than this, right? If it's a CIN1, the report comes as CIN1 of a colposcopy. Eventually, you need to do a colposcopy, boss. You need to do a colposcopy. And if your colposcopy report comes as CIN1, you know what? You need to chill out. Just do a co-test after 1 year. We'll do a co-test after 1 time. We'll do pyrocytology and do a co-test after 1 year. Alright? Now, this is because it kind of, mostly, regresses. But even if it persists after 2 years, then you need to do a treatment. All right. If it persists, you need to do a treatment. So yeah, in 2, 3, you need to go for coabulation, LEEP, LLETC, all of these procedures. It's an OPD procedure. You put it inside. It's a short procedure, minimal bleeding. It's removed till 10 mm. Send for HPE. All right. If it's recurrent, you can see this dysplasia and metaplasia recurrently. Can go for a simple hysterectomy. I would say definitely go for a simple hysterectomy. Okay. Seems good enough. Some things that need to be cleared before I leave is cone biopsy, conization, includes endocervix, exocervix, transformation zone. Do not do it in a pregnant. Disadvantage: it's an OT procedure, has needs of anesthesia, and admission is needed because you're actually getting into the cervix and into the uterus. Now, you do it positive when you have an adenocarcinoma of the cervix. You are suspecting an adenocarcinoma in situ. Your colposcopy is not adequate. Your TZ3 is seen, transforming zone 3. And yeah, that is about it. It's not visible. Transforming zone is not visible. Go for it. So that's cancer, carcinoma of the cervix, how you want to screen it. And finally, as I leave, certain things that we should do, as I said, endocervical curettage is done, which is a cone, and conization is done, a cone biopsy is taken, right? And you've got your diagnosis. Now, if your diagnosis is coming something like a cancer cervix, right, most likely it'll be an SAC. If it's an adenocarcinoma, pray to God, has relatively poor prognosis, but nevertheless, we stage the cancer. Stage 1, 2, 1A, 1, 2, 1B, 1, B2, B3, 2A, 2B, 3A, 3B, 3C, 4A, 4B. So 1A is now you're on the cervix, all right? So you need to think about going deep, lower, microinvasive. 3 to 4 mm is still 1A, all right? 1B is when it's less than 2 centimeter. 1B2 is less than 4 centimeter, greater than 2 centimeter. B3 is greater than 4 centimeter. All right. It's very important to understand that till the size remains about 4 centimeter. If the size of the cancer is less than 4 centimeter, you go for a trachelectomy. Usually you want to go for radical trachelectomy. Up to 1B, right? Post that, you do not want to get into a trachelectomy. You might just have to go for a hysterectomy probably. But the point is, if it's less than 4 centimeter, you can do a trachelectomy. After that, you need to go chemorado. Chemorado तो करना ही है most cases में. Para-aortic or pelvic lymph node तो करना ही है. 1A is basically pelvic. 3C1 is pelvic and 3C2 is para-aortic. 3A is when your pelvic side walls are involved, as like adnexa. 3B is when you're going into the heteroureter. B is for bladder, alright? B is for bladder. Okay, so I think, and 2 is when you're gone into the vagina. Very important, very important. Alright. Similarly, in adenocarcinoma, we spoke about 1A and 2A, right? So that's again important. Okay, and you use chemoradiation and brachytherapy, teletherapy. So that's about it.